Good evening, everyone. So, I'm Dr. Mrinal Pahwa. I'm a urologist and a kidney transplant surgeon at Gangaram Hospital, and I welcome you all on behalf of Conceptual Surgery. So, today I'll be taking a very short and introductory talk on adrenal incidentaloma, which are like one of the most commonly encountered adrenal pathology we see in surgery or urology practice. So we'll be going through a brief anatomy and physiology. I won't be going much into detail because that's a separate topic altogether, and we can have any number of lectures on that. So the definition and what constitutes adrenal incidentoma, how do we evaluate it, and what's a brief, very, very brief sky shot about the management part of adrenal incidentalomas. So, adrenal glands, these are two suprarenal glands found on top of the kidneys, and we know that it has a cortex and it has a medulla, and both of them secrete different substances. So, it's one of the most critical and essential endocrine gland of the body. Uh, Blood supply can be variable, not necessarily three arteries, but we can have blood coming from any number of arteries and supplying to adrenal gland. So it can be from the renal artery itself, from the inferior phrenic artery, directly from the aorta or the celiac plexus. So it has a very variable arterial supply. The only consistency is in the vein. Mostly it is one common vein, one major vein. On right side, it drains into IVC, and on left side, it mostly drains into renal vein. Lymphatics, they follow their own course depending upon the blood supply. So, brief snapshot about the physiology. We have three layers of cortex secreting three different substances. We have glomerulosa secreting mineral corticoid, which is 100 to 150 microgram per day. Then we have fasciculata, which secretes glucocorticoids, and then we have reticularis, which secretes the sex androgens. So this is about the cortex part. We have medulla secreting catecholamines mainly. Catecholamines coming from adrenal, they are in the ratio 4:1, as in 80% of them are epinephrine and 19% are norepinephrine. So in case of altered ratio, we can deduce that the catecholamine secretion may be coming from some other source other than adrenal proper adrenal gland. So that's about the applied physiology of this. Um, Coming to the definition of incidentalomas, these are unsuspected adrenal masses that we found on routine investigations, and which are more than 1 centimeter in diameter and identified on cross-sectional imaging, mostly performed for some other reasons. And we have a good incidence of 5%, and it increases with age, reaching up to 7% till 70 years of age. And about one-fifth of them are potentially surgically resectable lesions, and they require surgery eventually. So, in one of the largest series of incidentallomas, the results were that 90% were benign adenomas, 7% were metabolically active. Out of these 7%, 6% were secreting glucocorticoids, and 1% were aldosterone. So, these were the cortical lesions that were found. And another multicentric retrospective study, 85% were found to be non-secretory. 10% roughly had subclinical Cushing's, meaning glucocorticoid secreting tumors. Then we had 5% PO and roughly 1.5% aldosterenomas. So coming to the diagnostic evaluation, ultrasound is often found to be wanting in these cases as it's suboptimal. We don't find a good ultrasonic window to evaluate these lesions thoroughly, uh, more so on the right side than on the left side. So the imaging modality of choice becomes a CT scan. The non-contrast CT scan is the first and the single best modality in about 70% of the cases. When if we have a Hounsfield unit of less than 10 on enhanced scan, which means that there's a high intracytoplasmic lipid rich, and which is diagnostic for adrenal adenomas. Then the second line comes enhanced CT scan, as in contrast CT scan, which may show irregular margins with enhancing rim, which may be suggestive of malignancy. Then we have the CT washout studies. We have atypical adenomas which have 30% attenuation, more than 10 Hounsfield unit, and which can be lipid poor also. So differential becomes METs from RCC or HCC. So absolute washout of 60% at 15 minutes, it defines adenoma, and it also differentiates from ACC. So they have a rapid washout. So how do we calculate washout? This is just an example. We find out the Hounsfield units on enhanced scan and a delayed scan, and on unenhanced scan, and then that's how we found out whether what is the absolute washout or the relative washout. So, what is the Adrenal protocol CT then? Adrenal protocol CT, it comprises of non-enhanced images initially, with a cut of 5 cuts. Then we have the post bolus, post contrast enhanced, and the films are taken at +1 after 1 minute. And then we have another delayed washout studies, which are performed at after 15 minutes of contrast. So this is what constitutes a adrenal protocol CT, and which is different from a normal CCT or of abdomen or KUV. So MRI is roughly equivalent to CT, or we can say it's non-superior. So not much to choose, but then we don't have those readings of washouts to accurately define the tumor as having a rapid washout or a slow washout, so as to differentiate between benign or malignant. Functional imaging can be performed only in cases, in equivocal cases, when the diagnosis is not clear, or it's not clear whether it's a malignant or benign, or when we are unsure about the origin of the tumor. So various molecules that can be used. These are NP59 radial level cholesterol analog. Then we have metomidate C11. Then we have iodomethylmetomidate at I123. And especially if we are suspecting a FEO, then we use I123 MIBG, 18F dopamine, or gallium dotate scan. So, talking about the size, it's directly proportional to the malignant potential. So anything more than 6 centimeter, we presume it to be malignant until it's proven otherwise on CT findings or after histopathological studies. And 4 to 6 centimeters, they have 6% chance of malignancy. Labeling a 4 centimeter lesion as benign has 93% sensitivity and 42% specificity, whereas labeling a lesion as malignant at 6 centimeter has 74% sensitivity and 73% specificity. So, incidence of adenoma, it increases with age. If in younger, even a less than 4 centimeter can be a malignant tumor, and in old with other comorbidities, even a 4 centimeter may deserve only conservative management and wait and watch. So European guidelines, when we talk about the growth kinetics, as in the rate of growth of the tumor, so as to differentiate between benign and malignant, and any increase of more than 20% in diameter or at least 5 growth is labeled as clinically concerning, and it demands surgical resection of the tumor. and there is a 1 in 1000 chance of a malignant transformation of the tumor. So besides